Hello. Hello, everybody. Okay, looks like I'm getting feedback. Thanks, everyone, for being here today. I will have the honor to introduce myself. Dr. Halver is not here, so I've been a frequent flyer in this grand round, so I'm pleased to come back. My name is Ricardo Arbulu. I'm one of the infectious diseases physicians at Mary Greeley Medical Center. And we have a ostentatious title for our talk today, a very loft talk. We're going to try to tackle down some frequent questions that we get, and with that excuse or format, we will try to hit some very important points that we want to transmit to the primary care physicians from our specialty. So I ended up picking 3 of the many frequently asked questions that we get, and the purpose is to touch on topics that have to do with what we're trying to push currently: good antimicrobial stewardship, good use of antibiotics in this era in which antimicrobial resistance is building up and we are running out of options for many treatments. I hope that this represents for you a good mixture of newer treatments or newer discoveries, and most importantly, going back to that good and old treatments that we all need to do appropriate stewardship on. So here we plan to spend about 15 minutes in each section so you can pace your sleep and your lunch. So let's move on to the, excuse me, to the first question. So very common scenario and an iteration of this. In this case, it's an inpatient. We can extrapolate later to outpatient. So what is the management for somebody who appears to be failing treatment for cellulitis after 2 or 3 days? So I present you with a case, a real life one. So a 57-year-old man with diabetes, hypertension, obesity. He has venous stasis bilaterally. He complains or comes in with a history of 2 days of redness and swelling of his right leg. In the clinic where he is assessed initially, he has a temperature of 101, a white blood cell count of 12.4, and he is hospitalized based on his comorbidities and on the fact that he appears to have a severe illness. Excuse me. He's started on cefazolin IV, brand name Ansef. In my disclosures, I said that I will use some brand names just for familiarity. On hospital day number 1, you come back to round and you see that the leg is still having redness, and not only still having redness, but spreading. The temperature is still not quite normal. He's not febrile per se, but he still has a higher than normal temperature. On hospital day number 2, there's further spread of the cellulitic area, the extension of the erythema. And this picture is from day number 1. I did not have a picture of subsequent days, but just picture that this redness is simply spreading out. At that point only, a CRP level is obtained, and it's elevated at 3.5. Normal level for our institution is 1. Blood cultures with no growth. And for people who would have this question, there's no history of trauma. This came spontaneously. There's no obscure exposure that I'm hiding from you. And this little dent that you see here, I wanted to make sure people don't think it's a pustule. It's just a blister that ruptured. So what is the next best step in management? And we don't have our audience response today, so we can do raise hands, but let's go over the options. So switch to vancomycin IV, switch to piperacillin tazobactam, aka Socin, switch to a combination of vancomycin and Socin, or continue as cefazolin. So please raise hands. How many of you would want to go with option A? Nobody? Okay, great. How many would like to switch to Socin? One person, two people. How many would want to switch to vancomycin and Zosyn? A few more. Or how many would like to continue the cefazolin? A couple more. So pretty spread out. Nobody wanted to do the vancomycin only. So we will elaborate on this in the next few slides, but what the knowledge that is needed to tackle down this situation is the differentiation between non-purulent and purulent cellulitis, or more broadly speaking, non-purulent and purulent soft and skin and soft tissue infection. So the summary of this slide is that when there is pus, let's start with that, namely a boil, a foreign gall, a skin abscess, or bursitis, plus minus surrounding inflammatory changes, well, that is probably a staphylococcal disease, whether it is Staphylococcus susceptible to methicillin, MSSA, or MRSA, but all in all a staphylococcal disease. And the treatment for that is drainage. You need to look for where the pus is harbored and you drain. The role of antibiotics as adjuncts is a whole separate issue, and there's specific indications for them. But the point is, if you see pus on a skin and soft tissue infection, you drain, and then you worry about antibiotics as adjuncts. But our case appears to be a non-purulent case, and that is the syndromes that we see in non-purulent skin and soft tissue infection include erysipelas, which is the most superficial one, cellulitis, which is our patient, necrotizing fasciitis, which is a more severe extreme. Now, here's the main teaching aspect of this. This is a streptococcal disease easily in a 95%, with a 95% chance. So you focus on treating streptococcus. And since there's no purulence, there's nothing to drain. So what are the antibiotics that treat streptococcus? It's 2017, and we're still good with most streptococci being susceptible to good old beta-lactam antibiotics. Starting with penicillin. Now we're moving on away from our case and thinking outpatient. So for a mild cellulitis, okay, that you've determined it's a erysipelas cellulitis, likely streptococcal disease, it is still okay to use good old penicillin VK. A moderate case should probably best be treated with cefalexin, and this is not an issue of resistance. That is a very important concept. It's more an issue of delivery of the drug to the tissue, bioavailability. And if the patient is allergic to beta-lactams, and I should put a big asterisk, truly allergic, and we can elaborate later on why this is so important. You know, most people who claim a penicillin allergy don't have it. We've spread this word in different opportunities to this audience. For those people, then you use clindamycin. So as you see here, the list of antibiotics are the good old ones. And the treatment should be the good old drugs for streptococcus. All this long list of antibiotics that you see here for staphylococcus, for purulent skin and soft tissue infections are not necessary to treat this streptococcus. They are overkill. Not even on this table do you see drugs that are primarily used to treat gram-negative rods. Why? Because that is the exception when you see cellulitis. Probably the 5%, not probably, that's the 5% remaining here would be a mixture of staphylococcus and gram-negative rods. So let's unfoil this. So I refer you to a recent study, very well done, although relatively few patients, but a very elegant study from the Netherlands, just published last year. So this was a prospective cohort. They followed patients with cellulitis. The median age was 54, and they included all adults up to 94 years of age in this study. And it had a good mixture of people with comorbidities. And they settled for finding out the difficult issue to prove usually. What is the etiology of cellulitis? I mean, those who have been practicing for a while will notice that we seldom are able to recover an organism in cellulitis. It is the exception, and this is well known in the literature, that usually we get 5%, 3% rates of positive blood culture, so we should not count on having an organism to treat. Therefore, the treatment should be empiric. So they were pretty aggressive in trying to find what the etiology is or was. They did acute and convalescent titers for Streptococcus using anti-streptolysin and ADV titers. What is important here is that this is not something we would use in clinical practice, because an acute titer, then a convalescent titer would be like after the patient leaves the hospital, decisions are made, the patient is either cured or not cured. So this is for research, but it gives us good insights on the etiology for this study. They did blood cultures. Tissue cultures, this was pretty aggressive. Some patients just got a biopsy in the site of cellulitis. And also they went ahead and swabbed the skin. You know, most people know in this audience that swabbing the skin is usually of no use, but again, for the purpose of research, that was an interesting thing to do. So what did they find? So out of 203 patients with non-purulent cellulitis, so this is the case of our patient, 146 were proven to have or had confirmed beta hemolytic streptococcus, okay, that's a BHS here, by strict serologic criteria or by positive culture in blood or in tissue. Out of those who were not confirmed to have streptococcus by these gold standard tests, 27 met what they define as a clinical criteria. They say, let's just treat them with penicillin and see, if they respond to penicillin alone, since penicillin doesn't kill staphylococcus for the most part, and certainly does not kill gram-negative rods and other obscure pathogens, it must be streptococcus. And indeed, by that criteria, they gained another 27 people. So if you look at the whole picture, 85% of people were confirmed or had a probable streptococcus as the cause of their non-purulent cellulitis. And what they don't report well is what other antibiotics were used, but they imply that they did not escalate to treat MRSA, so probably vancomycin wasn't used that much. So that is a great accomplishment in study, because normally we do not know what causes cellulitis, and they were able to demonstrate, well, most of it is indeed streptococcus. From this same study, this is also, this is very powerful to me. These are really little numbers, but look at the detail. So when a blood culture was positive, and as we said, out of those 200, only 6 were positive, so 3%, that's in accordance to the literature. Whenever a blood culture was positive, it was a streptococcus. And you see the different types of streptococci, but all in all, streptococcus, for the most part, susceptible to, as we said, the good old beta-lactam antibiotics. When they did this aggressive tissue of the skin through a punch, for instance, or when they somehow got some sterile site culture, these were cellulitis in the face, in the arms, and the legs, and I couldn't find exactly how they decided to do this in some patients, but when they did this, well, a number of patients were negative, but when something grew, guess what? It grew streptococcus. So probably that 85% is more like a 95% or so, and everybody had streptococcus, and everybody eventually got better. So that kind of gives you a hint of what, where we're going with the question, right? So we need to continue treating streptococcus. In that particular vignette that we presented, the antibiotic that treats the narrowest and goes treat the streptococcus and not much else is that cefazolin. Let me give you something more clinical. We talked about the etiology, but this same cohort published a different study. It's the same people, different study. Now they ask the question, when do people start getting better? So we have this colorful slide here, and hopefully you can read. Here we have pretty much every relevant parameter that we follow when we assess the patient on follow-up with cellulitis. So we want to know when the lesions stop spreading, right? We want to know when there is improvement of local inflammation, meaning the redness and the temperature. This green color is a combination of both. The purple is resolution of the fever, and then a number of laboratory parameters that we also follow. And what you can see here, I mean, the conclusion from this slide is that by all relevant parameters, people eventually get better by day 3 or so. Look at 90% improvement of all these parameters. The fact that people were not better on day 1 did not predict that they were going to fail later. And what I had a little bit of trouble when I was reviewing this is, wow, everybody got a lot better by day 3. And they're actually looking, well, you have to add up a day, right? It's day 3 on antibiotics. And another comment that is made is in the article is that people who have had longer cellulitis by the time they came in, they started to get better sooner. And they interpret that as, you know, cellulitis is just following its course. So a lot of data to support, and this is in accordance to older data, that all we need to do is probably just holding the patient's hand, keeping the good anti-streptococcal treatment, and they will eventually get better. This is another way to present the same data. So as you can see here, the green represents improvement. So even though people were not much better after 1 day of treatment, by day 3, most of them were. Now, this doesn't mean cured, okay? And this is illustrated in this next slide. So what is this red stripe here? This represents, so this is a post-treatment, excuse me, this is end of the treatment right here. So when they assess patients at the end of the treatment, up to 60% had residual inflammation. So it is interesting that they accepted a little bit of redness, a little bit of temperature. They said, okay, we're done with the antibiotics. You probably just have some inflammation after all the bacteria have died, and we'll see how you do. So they followed post-treatment. This is about 30 days, if I remember correctly, post-treatment. And people still had some inflammation, and most importantly, very few had deteriorated. In a small percentage, less than 5%, ended up readmitting, so frank failure. So in other words, I think all this data builds up to the fact that, let me summarize rather. So treatment of cellulitis that is apparently failing. Well, the first thing that you need to ask yourself is, do we have the right syndrome, right? If you have non-purulent cellulitis, another way to put it as I phrase it there, if you are not missing purulent cellulitis, which needs to be treated with drainage, you are probably in the right track because most antibiotics that we put on that previous slide will treat Streptococcus. If this is truly non-purulent, just wait. Just keep treating, and should go without saying, we didn't spell it out, but patient needs to rest with the leg elevated. That's a well-established strategy to decrease the inflammation. We can give lots of cefazolin, but let's make sure that the dosing is appropriate. Very large patients will need greater doses. Sometimes we play low ball with dosing because we're fearing damaging the kidney, but we can use the help of pharmacy to make sure that we're giving an appropriate dose. And here's a bonus for you. I mean, at times people will just have redness from venous stasis. So be attentive to that. So the same process, the same thinking will apply to outpatient. Just replace cefazolin by cefalexin, which is oral, and you can apply the same logic. So does this mean we don't want you guys to consult us? That if you call us about cellulitis, we'll just tell you keep the antibiotics and they will get better? No. In fact, we want you to consult us, not only because we want business, but also because it's evidence-based. So there's a very nice study. This is recent, and I apparently did not include the year of this, but it's 2016 or 2015. The title is self-explanatory. Infectious Diseases Specialist Management Improves Outcomes for Patients Diagnosed with Cellulitis in the Emergency Department, a double cohort study. So the summary of this study, or the conclusions, were that when IV was involved, there was, at the end of the day, lower likelihood of recurrence. There was lower likelihood of hospitalization. We're not talking rehospitalization, but this patients at times were sent directly from the ER home. And that's an interesting concept because at times you may think, okay, let's not bother them. Let's see how the patient responds. And they are not that sick. We probably, are second guessing that we put the patient in the hospital. Let's not consult ID yet. But you have to look at it the other way around. Like if ID gets involved, there is a chance that they go home one day earlier on, for instance, home IV antibiotics or OPAT, outpatient antibiotic therapy. Or they may just, ID may come and do this very cool thing, which is identify mimickers of cellulitis, saying there's no cellulitis. You don't need to treat. This is venous stasis. And this is something that occurs in our practice, and this is something that they found in this study. ID can also help with this 5% that we left hanging before. What happens if the cellulitis is non-streptococcal? Well, you have to think, this is not a comprehensive list, but you have to think along these lines. If there has been a dog or a cat bite, there's going to be other organisms involved. If there's something more specific, like a lake or river water exposure, there's going to be other organisms involved. Specifically in the Gulf of Mexico, you think of Vibrio vulnificus. So this kind of things, we can help with that because that's what we do. And so bottom line, there is value of involving ID for seemingly innocent cellulitis that is admitted. Because if you're thinking the patient needs to be admitted, you're either thinking they are severely ill, or if you are undecided about it, we can help push the patient back to the outpatient realm. So that concludes our first section. We'll have questions at the end. Let's move on to a more esoteric question. So there's no case for this, there's just a question. So during workup of acute diarrhea of an adult, I see no pediatricians. I prepared for them to kind of ask questions today. So during workup of an adult, the PCR panel, and you guys are familiar with what that is, and we have it in our institution, the PCR panel turns out positive for both this EPEC thing and norovirus simultaneously. So should we treat with antibiotics is a question. So the embedded question is, what is the significance of EPEC? What is the significance of norovirus? So we need to gain some literacy on what this EPEC means. So EPEC, along other soup of letters like that you see right here, is what we call a diarrheogenic pathotype of E. coli. What does that mean? So these are strains of E. coli. So let's back up even a little bit. So I think people are familiar with the fact that E. coli is a normal commensal of the gut. It lives with all of us. It's indeed one of the most frequent ones. So, but these pathotypes are strains of E. coli that have acquired genetic material that turns it virulent. So they're no longer that innocent E. coli mellowing out with you, but they have the potential to cause disease. So it's interesting to look at the history of this because they've been discovered slowly, starting in the 50s all the way to the 80s. and they've been classified by the clinical syndrome that they caused on diagnosis. And they were identified through heroic, very involved methods in the lab, because PCR, which is our battle horse nowadays, was not available. So in addition to the clinical syndrome, they were identified by combining antigen detection and real-time PCR when it became available in the 70s or 80s. So the point that I was trying to make here with these images is that in the lab, E. coli that is living with you as a commensal is indistinguishable from all these E. colis that are potentially pathogenic. So what I'm trying to get at is that in the past, and not the distant past, so prior to the 2010s, in our institution prior to 2015, if I'm not mistaken, that we started using the PCR, we were blinded to this reality that we had patients who carried all these organisms, with the exception of EHEC, also known as STEC, enterohemorrhagic E. coli. We'll talk about it a little bit later, but this was the only one, and it's a clinical important one, that we were able to identify through regular bacterial methods. But now it's like we opened Pandora's box with this new GI PCR panel, where all of a sudden seeing all of these guys in whom the clinical significance is not that clear. But let's go back to what we do know, and I do not expect you to walk out of here knowing this. Let's just get the big picture. So these are all the pathotypes of E. coli that are reported on this novel GI PCR panel, or GI multiplex is also called, because it detects multiple pathogens. And you can read their names here. I try to summarize them in order of clinical importance. The one that you should be most familiar with is enterohemorrhagic E. coli, or Shiga toxin producing E. coli. This is one out of 2 E. coli that has a potential of causing diarrhea with blood, or dysentery. In particular, we are worried about this strain called O157H7. This is a subset of this type of E. coli, because that is the one that accounts for 90% of the very deadly HUS, hemolytic uremic syndrome. This is a syndrome that affects children, mostly. It can affect adults, and it consists of renal failure, severe anemia, and it can lead to death. So this was first identified, this O157 was first identified back in the 80s during an outbreak. And CDC promptly developed a method for labs to be able to identify it without the use of a reference lab. So this first line, this is pretty much what we have been able to identify in the past, and that's about it. But now, as I said, Pandora's box is open, and we have all these other guys that we are seeing routinely on our PCR panels. So, as I said, I try to list them in order of severity of clinical importance. And down here is the one in the example, EPEC, enteropathogenic E. coli. This was actually the first one discovered back in the 50s, and it was discovered as an agent of infantile diarrhea. What we should hold on to as a well-accepted piece of knowledge is that children are way more susceptible than adults to develop disease. And everything that you see in blue here does not cause bloody diarrhea, but just watery diarrhea. So that's what we know about that EPEC. So it's usually an infantile disease, mostly in the developing world. We didn't see much of it in the developed world. And so we'll leave it there. So let's just take another angle to this, and just to be on the same page, this is what we're talking about when we say GI panel. It's this little magic box. You put some stool in it, and it tells you the truth. So I never thought of it like that. It's a PCR, polymerase chain reaction based test. So it actually very astutely goes in looking for all the relevant pathogens that you care for on a stool, right? And I didn't put a comprehensive list of it, but you'll find norovirus, Campylobacter, C. diff, and then all these famous pathotypes of E. coli are part of this litany of things that you can find on the PCR panel. So the technique, just again, this is a very rudimentary way to describe it, but what it does is, and I don't claim to know the full details of it either, but the point is that it looks for a highly specific sequence to each pattern. So just to give you an example, when we talk about E. coli pathotypes, they all have this particular way they cause disease. For instance, the STEC, Shiga toxin producing E. coli, which is the same thing to say enterohemorrhagic E. coli, produces this evil Shiga toxin. That's what actually causes the hemorrhagic remix syndrome. And that is what this little box looks for. So it can tell you with high specificity, okay, that's what you have. That particular example has a little bit of a flaw because, to complicate matters, other organisms can produce it. So it runs some algorithms there combining all these sequences, and it spits up to you, okay, what you have is probably this organism. It's all in all very specific, and it amplifies just a little bit of organism that may be found there, a little bit of genetic material, not even the whole organism needs to be present. So you can expect a lot of positive results even if just some random genetic material was present, even if the organism was dead long time ago. Does it make sense? So again, multiple relevant pathogens are tested simultaneously. So let's look at a study that has precisely asked the question, okay, now that we opened Pandora's box, how has this changed the outlook of the patients who submit diarrhea? So what are we finding? And they use the same assay we have, the film array. So what are we finding? What this study asks is, what are we finding in the real world with this GI panel in patients who submit samples for diarrhea? So this is the frequency of pathogens detected on greater than 700 stool samples, and they sorted out by the diagnostic approach employed. So the film array or GI panel is in red, and the green is essentially the traditional methods. So what you can see right off the bat is that EPEC, which is the one from our example, ETEC, STEC, so all these E. coli pathotypes were essentially non-existent before. As consequent to what we just said before, it was really hard to identify in the lab. They were sent to referral centers, and we didn't know about that. And now all of a sudden we have all this red bar with, in this case, 107 versus 3 prior. These are absolute numbers of this EPEC. The other conclusion from this is that EPEC appears to be, across the board, the #1 found pathogen. So how about this other graph where we assess not only the total frequency, but what is found in conjunction with other pathogens. So the dark blue would be, the dark plus the light actually is the total frequency. And the light blue provides you an idea of how much of that particular pathogen was found when a different pathogen was found as well. So you can see that EPEC still leads the list. It is found by itself a bunch, but it is found in conjunction with other pathogens as well. So what does that mean? That means we're detecting a lot of things. And does this mean that the patients are infected with 2 different things at a time? The truth is we don't know most of that answer. Let me just swipe through this and take a step backward. So what is the significance of that EPEC? Let's try to tackle that from a different angle. Let's go ahead and look what we know well. So back since the 80s, the mechanism by which EPEC causes disease has been well identified, and this is a beautiful picture that shows you that there's actual damage by this bacterium that can be caused in the intestine. The bacteria comes, it forms some attachment with the enterocytes, with the cells of the intestine, it breaks them apart, and then it forms this nice comfortable pedestal where it just sits. Very convenient. So we know that it has the potential to do this, but now we know that there's a lot of people who have it. Is this happening on everybody? So there's a study for that. So enteropathogenic E. coli, EPEC, faux or innocent bystander, published in 2015. And the answer to the question is yes. It turns out that matters complicate more. There's typical and atypical EPEC. And this has been known for a while. But the bottom line of this chart is that the typical EPEC has not only the, let me back off, EPEC is defined by some virulence factors that allow it to do this, what I just showed you here. So the virulence factors that allow this bacterium to cause this pedestal change configuration, that's what defines EPEC, and therefore both typical and atypical have that. But in addition to that, the typical EPEC has something with the flagellum, let me leave it vague like that, that in animal models has been shown to favor this adherence that we showed that happens more efficiently. So probably what we're seeing is that a percentage of people have the typical and they do get sick from it, while the atypical is an innocent bystander. That would be a very bold conclusion from the data we have. Importantly, the test that we have is not there yet. It cannot tell them apart, and I don't know if I want them to tell them apart. I want researchers to tell me what's going on first. So back to our question. We took a lot of detours there, but the answer to this question, you probably knew it before knowing any of this. Go back to your clinics, right? So do you need antibiotics was a question, and the answer is no, because most non-dysenteric diarrhea in adults, because rarely, the non-dysenteric diarrhea in adults ends up needing antibiotics to get better. You knew that. Now we're stuck with this new information, extraneous information as you wish, and putting it in context, it appears to be that we're just learning that this EPEC is either the cause of some of these syndromes and it's getting better on its own, or it's just an innocent bystander. We don't have the precise answer, and let the ID doctors figure out, while you just, for the most part, I don't want to say ignore, but put this EPEC in context, right? More than likely you will find C. diff, norovirus, or something else. I want to call your attention to the scenario if you find this as a sole pathogen, okay? And I'm talking about adults. If you find it as a sole pathogen, the patient has persistent diarrhea, the patient is severely ill, please discuss the case with us because we're all learning about this. Kids, as I mentioned, are much more susceptible. So if you find this on a child, that's way more serious. And it is probably a culprit of disease, and a separate chapter is whether the children need antibiotics or not. The question was about in an adult, and I want to keep it simple like that. We're going to skip through this slide and go straight to the grand finale, which is a separate common problem, cystitis, urinary tract infection. How to treat when apparently the patient is allergic to everything or they are resistant to everything. So this is a 67-year-old female who has diabetes, hypertension, obesity. She does have recurrent cystitis, recurrent urinary tract infections. And in the past, somebody had prescribed oral suppression with Bactrim. She's no longer on that, and she keeps having the cystitis. So she does not have any known structural reason to have recurrent cystitis. She's had a CT scan of the abdomen that is normal, and she presents with classic symptoms of cystitis: burning, transient incontinence, no fever, no chills, no back pain. Her urine culture shows some E. coli that is resistant to everything you can think of is oral to treat her with. So amoxicillin, clavulanic, all the cephalosporins that are tested there, ciprofloxacin, levofloxacin, it is intermediate to nitrofurantoin and is susceptible to intravenous antibiotics. In addition, the lab reports that this is an ESBL. I didn't put it there. An ESBL is an extended spectrum beta-lactamase, which pretty much tells you there's a big pattern of resistance like that. So what would you use? Would you treat this person with an antibiotic that she is intermediate to? Well, you're reading the options there, but it's basically oral, IV, another oral that you may not be familiar with, you may be, or you can say, you know, this is cystitis, it is going to get better. So how many go with A? Okay, that is a reasonable choice on a not very ill patient. So how many want to put a PICC line and give ertapenem, or just send to the infusion center and give ertapenem IV? How about fosfomycin orally times 1? The IV people chose that. No treatment, and you know, no treatment is also a reasonable choice if there is really no other treatment available, but the patient is having symptoms. You know, cystitis doesn't generally turn into pyelonephritis, but this is an older individual you may want to treat. So the treatment or the choice that I wanted you to pick is fosfomycin. You can try nitrofurantoin, and if she fails, you can build a case for fosfomycin. So what is fosfomycin? So this is not a new antibiotic. This is an antibiotic discovered in 1969, and it has been in use since the early 70s. It does something very powerful. It does something very similar than all these nice beta-lactam antibiotics do, which is it inhibits a cell wall synthesis of the bacterium. That's the most efficient way to kill bacteria. And it does so at an early stage, so both gram-positive and gram-negatives get the effect. So as a consequence of this, it kills both gram-positives and gram-negatives, a broad-spectrum antibiotic. It has not been widely used in the US and elsewhere for the most part, so it remains susceptible to a lot of things. It's FDA approved, even though you may not be familiar with it, and it's on the guidelines for treatment of cystitis, specifically for uncomplicated cystitis. So again, this treats essentially all relevant bacteria that cause cystitis. So Enterococcus faecalis, Staphylococcus coagulase negative, E. coli, Klebsiella, Proteus, Pseudomonas. This is essentially the list of bacteria that usually cause cystitis. So we mentioned ESBL. So ESBL tends to, the definition of ESBL that it is resistant to a number of beta-lactam antibiotics, but in addition, it tends to be resistant to quinolone, so it knocks down your options, but there's no increased resistance to fosfomycin. And to top it off, the dosing is quite convenient. You give one dose. It comes in a package, in a pack, and I'm going to show you that in a second, and you give it once for uncomplicated cystitis. You can treat complicated cystitis, and let me get this definition out of the way. The literature is all over the place of what uncomplicated and complicated means, but as a general rule, uncomplicated cystitis is an individual with no known problems in their urinary tract. Some are more stringent and say only young ladies premenopausal, and no men are considered uncomplicated. So the definition is fluctuant, but for the most part, our patient would meet an uncomplicated cystitis definition, and we may, if she fails, redose, as the second bullet point says here, every 48 to 72 hours due to the long half-life of this. antibiotic. No renal adjustment needed, and the big warning is do not try to treat pyelonephritis, meaning infection of the kidneys. Prostatitis is, for the most part, evolving knowledge at this point. But pyelonephritis, no, they can get really sick. This is not going to penetrate in the kidney. So that's a big fault of this antibiotic. It does not penetrate tissue. It just concentrates in the bladder, and that's how it's so good. For familiarity purposes only, I'm not endorsing this product. This is the brand name, and this is how it looks like. It comes in a pack, and this is the instructions the patient will get. Now, we have 2 more minutes, and I just wanted to show you empiric data. So there's a meta-analysis that compare this to the usual antibiotics we use. And not surprisingly, I'm just going to skip through this. This is a summary of fosfomycin versus other antibiotics. And if you're familiar with this kind of graph, everything that falls in this line means that the efficacy of the drug being compared, in this case fosfomycin, is similar to the other drugs that were used for comparison. The other drugs for comparison were quinolones, ciprofloxacin, levofloxacin, trimethoprim or trimethoprim sulfamethoxazole, a variety of beta-lactam antibiotics, and nitrofurantoin. We use all those for UTIs. So fosfomycin was no different in terms of efficacy. To top it off, they tried this on pregnant women, and the reported side effects, this is what this shows you, was either favoring fosfomycin. There's got to be a catch. Cost. So not all pharmacies, cost and availability. So not all pharmacies carry fosfomycin, and it takes, well, I put a conservative 24 hours there, but it at times takes longer. And many times you learn that Medicare does not pay for this period. The out-of-pocket would be $45 to $90 per 3-gram dose. The susceptibility to fosfomycin is not commercially available usually, but you don't need it because it's 95+% a drug that's going to work clinically for your isolates for UTI. Again, I insist, no pyelonephritis, just cystitis, bladder infection. And despite the fact this kills too many bacteria, you would think, okay, this will kill all the gut flora and we're going to end up with C. diff, but that is not true. That is not observed. And the reason is because it doesn't kill anaerobes in the gut like other antibiotics. So it doesn't kill anaerobes, period. So the risk for C. diff is low. So that's actually a pro. So to answer number 3 and to wrap up, what's an alternative to treat cystitis when there are seemingly no oral options? Consider fosfomycin, an otherwise forgotten drug that has a niche. It has this niche of treating cystitis. It's in the guidelines. It's FDA approved. It is comparable to first-line common treatments of cystitis. And the spectrum of treatment of this drug is essentially a list of everything that causes cystitis usually. So it is a great drug from that point of view. It can be used in pregnant people. And keep in mind that complicated cystitis can be treated with repeated dosing, but this drug, for the third time I say it, should not be used for pyelonephritis. And I exceeded the time by 1 minute. I'm open for questions. I understand people need to move on. This, since it was not printed, will be available. You just email me. I'll send it on a PowerPoint, and I can send all the references for you. Thank you. Oh, a question.
Thanks so much.
Yes, sir.
For the GI panel,
Yes.
if we have people coming in that don't have a fever, they don't have bloody diarrhea, do we need to get the GI panel on everyone? Right now, I'm kind of doing that, and I think it's overkill.
Absolutely. Okay, let me start by saying we're learning, right? So an adult, right, who comes in who just has acute diarrhea. So let me kind of return the question. How would you manage that patient? And I'm not challenging, but trying to think through. how would you manage that patient like 10 years ago when this was not available?
Sometimes get a culture.
Sometimes, right? So, and what we got from that culture as presented is we could learn things. We just talked about E. coli, different strains and pathotypes, but the culture is useful also for Salmonella, Shigella, Campylobacter. Now, say you found those, right, in an adult who's not having fever, who's not having dysentery, not having blood, you're probably just going to wait. And even if they have blood, it's well described that you can just sit and wait. So in other words, if you're going to wait anyway, why bother, right? So the GI panel is certainly useful for detection of, let me go back. So I'm limiting the discussion to this E. coli pathotypes here, but it would be very relevant to find out that the patient has enterotoxigenic, for instance, E. coli. That certainly can be, you can wait, but it can benefit from a dose of antibiotics safely, right? But I agree. I mean, overall, you're not gaining much. No, if you're concerned about C. diff, well, you ordered C. diff testing, right? And correct?
So I've had the specific C. diff testing not agree with this panel.
That has happened, right?
Yeah.
Yeah. They are slightly different. The C. diff testing that we have in-house is actually an algorithm, right? It starts with a test called a GDH and a toxin assay. If one of those is positive, it reflects to a PCR similar to this. So it's a more involved process. I would say that supersedes the results of the GI panel because that's a structured test specifically designed to be more sensitive and specific for C. diff. And what trumps everything actually, Dr. Eris, as you well know, is the clinical judgment, right? So if you find C. diff, discrepant results, it doesn't make sense that the patient has C. diff. Could he be colonized? Could it be just a straight, I mean, I won't venture to say we get just random lab errors on that or overcalls, false positives, but we do get a bunch of colonizers. So I would say, as a general rule, if you have conflicting results, I would believe what we call now C. diff complete, which is the dedicated C. diff test, and disregard the other one, which may be reflecting colonization. That makes sense? So back to my previous point, if you're concerned specifically about C. diff, you should order C. diff. You should not order GI panel, right? Because you'll get a lot of strenuous information and a lower quality C. diff assay. Question by Dr. Fulton. It's going to be challenging.
Could you comment on people with chronic indwelling Foley catheters and the use of Fosfomycin? Many of those patients are the ones that do have multi-drug resistant pathogens, and is Fosfomycin a good agent for people that have a chronic Foley draining the bladder?
Well, that's a very good question. In general, we favor Fosfomycin for uncomplicated cystitis. We can treat complicated cystitis, and by having a catheter, that would be automatically a complicated cystitis. Would you agree? So I think it should be, as you taught me, a shared decision making with the patient, because the risk is, and we've seen that sadly on a recent case, you can fail treatment and people with underlying urological pathologies can get pyelonephritis from a poorly treated cystitis. So there's a risk involved, right? Now, you think for it, this is an antibiotic that concentrates in the bladder. It kills bacteria well in the bladder. If the infection is just there, it should work just fine. That's theoretical, right? but the stakes are higher when you're treating a person like this, right? I mean, I'm assuming you're not implying a kind of a sub-question is like, should we treat them at all because they have a catheter, they may have asymptomatic bacteriuria. You're talking about real cystitis, right?
Yeah, no, that aside, I think one concern I've had with people with Foley catheters is that because the drug works by concentrating in a location, I've always felt like drugs like Fosfomycin, ibuprofen that works in the same way with the chronic catheter, you're killing the bugs in the bag, but probably not in the bladder where you're worried about.
Just because it drains all the way by gravity and it just passes the bladder.
Right, and I didn't know if when you were kind of preparing for this, did you see any Fosfomycin being used?
Right, I didn't. I don't know if that data is out there. I was just trying to reason through it, and I think the stakes are higher in such individuals, and there's things like what you mentioned, which makes total sense. We may be missing some other consideration like that, why fosfomycin can be used. So appreciate the question. So I think all three questions end up in you consult ID because I try to make the point that there's reasons for discussion. Probably a fosfomycin, feel free to start using by yourself and get your feet wet on that, and the more people that prescribe, we'll eventually see some price drop, and we would love to see how your patients are doing on that. We would love to get some feedback on that. Any other questions? I have more time, but I know people need to go, so I'll be happy to take questions on here if you wish. Thank you.